All right, if you're deep in study mode for your exams, you know the ECG can feel like trying to read some kind of ancient, secret code. But what if I told you that in just the next few minutes, we can crack it? We're going to break down the key patterns and arrhythmias you absolutely need to know, using a really high-yield, exam-focused framework. Let's do this.
Here's the game plan. We're going to start with the absolute fundamentals, what an ECG even is. Then we'll build up from there, getting a handle on the 12-lead system and what a perfectly normal heartbeat looks like. And once we've got that down, we'll dive into the arrhythmias you have to be able to spot, the ones that are too slow and the ones that are way too fast.
You know, it's pretty amazing to think that for more than 100 years, the electrocardiogram has been one of the most critical tools in a clinician's toolkit. It's our non-invasive window into the electrical life of the heart, and it's absolutely essential for catching everything from a heart attack to a life-threatening rhythm problem.
And the history here is pretty cool. I mean, this whole thing started way back in 1887 with Augustus Waller. It was then refined by Willem Einthoven, who actually won a Nobel Prize for it, and then Sir Thomas Lewis really cemented its place as a core diagnostic tool. It's this incredible legacy of innovation that we get to rely on every single day.
So, how do we get this amazing electrical picture of the heart? Well, that brings us to the 12-lead system. And here's the first thing to get straight. Don't think of it as 12 wires. Think of it as 12 different cameras, each one giving us its own unique angle of the heart's electrical show.
And this is how it all comes together. It's kind of wild, right? We only use 10 electrodes, the sticky pads, to create those 12 different views. The 6 limb leads give us a look at the heart in the frontal plane, kind of like looking at it straight on. Then the 6 chest leads, the precordial leads, they give us a view from the horizontal plane, almost like we've sliced the body in half and are looking down at the heart.
Now, these cameras work in 2 different ways. The first 3, leads I, II, and I3, are what we call bipolar. They're measuring the electrical difference between 2 points. The rest, though, are unipolar. They measure the electrical juice at one specific spot, compared to a calculated 0 point. It's a subtle difference, but it's key to how we capture the complete picture.
Okay, you can't get a good ECG without putting the leads in the right spot. And for any exam, you just have to know these precordial landmarks cold. It's a pretty logical sequence. V1 and V2 are your anchors, right there in the 4th intercostal space on either side of the sternum. Then you find V4 first. That's in the 5th intercostal space, mid-clavicular line. Pop V3 right between V2 and V4, and then V5 and V6 just follow that same line around the side.
All right, so our cameras are all set up. Now, what are we actually looking at? Let's take a single, normal heartbeat and break it down into its pieces. Seriously, if you can get this down, you've learned the language of the ECG.
First up, you've got the P wave. This little bump at the beginning, that's the signature of atrial depolarization. It's the electrical signal that kicks off in the heart's natural pacemaker, the SA node, and makes the top 2 chambers, the atria, give a little squeeze. A normal P wave is small, it's fast, and, this is key, it should be pointing up in leads I and II.
Right after the P wave, we have the PR interval. Now, this isn't a wave, it's a measurement of time. It's basically a pause. It tells us exactly how long it takes that electrical signal to get through the AV node, which acts like a gatekeeper to the main pumping chambers. That normal range, 0.12 to 0.20 seconds, is a number you just have to burn into your brain.
And here is the star of the show, the QRS complex. This big spiky thing represents ventricular depolarization. That's the massive electrical signal that tells the big, powerful ventricles to contract and pump blood to the body. And the most important thing here is how long it takes. Anything wider than 0.12 seconds is considered wide, and it's a huge red flag that there's a problem with the wiring inside the ventricles.
And finally, after all that action, you need a reset. That's the T wave. It represents ventricular repolarization. Think of it as the ventricles electrically recharging, getting ready for the next beat. And if this wave looks weird, it can be a major clue to things like a lack of oxygen to the heart or some wonky electrolyte levels.
Okay, we've got the alphabet down. Now let's start reading the stories of when things go wrong, starting with when the heart gets too slow. We're talking about bradyarrhythmias, and for your exams, that really means you need to understand AV blocks inside and out.
The simplest one is a first-degree AV block. The best way to think about this is like a consistent traffic jam at the AV node. The signal always gets through, so every P wave does have a QRS that follows it, but it's always delayed. The only clue you have is that PR interval is just stuck, consistently longer than that 0.20 second limit.
Now this is where it gets really interesting, and it's a crucial distinction. In second-degree AV block type 1, also called Wenke-Back, that PR interval gets longer and longer and longer until, boom, a beat just gets dropped completely. It's a pattern of going, going, gone. But in type 2, the PR interval is totally constant, beat after beat. But then suddenly, out of nowhere, a beat is dropped. This one is way more dangerous because it can progress to a complete block without any warning.
And this is the end of the line. Third degree or complete heart block. The wire connecting the atria and the ventricles has been completely taut. There's zero communication. So the atria are just doing their own thing, making P waves, and the ventricles have kicked in their own much slower backup pacemaker, making QRS complexes. They are completely dissociated, beating totally independently of one another.
All right, let's flip the script. We've done too slow, now let's talk about way too fast. When the heart races, we call it a tachyarrhythmia. And the very first question you have to ask yourself is, where's this coming from? Is it starting above the ventricles, a supraventricular tachycardia, or is it coming from the ventricles themselves?
This slide is just a fantastic high-yield cheat sheet for the common SVTs. For atrial tachycardia, you're looking for clear P waves, but they'll look different from the normal ones. For AV-NRT, the most common type, that P wave is often hidden, completely buried inside the QRS. And for atrial flutter, well, that's the classic one. You see that sawtooth pattern? That's your giveaway. No flat baseline, just those flutter waves.
And then you have the king of all arrhythmias, the most common one you'll ever see, atrial fibrillation. This is just total electrical chaos in the atria. The two things you have to know, the hallmarks are, 1, you can't see any real P waves, and 2, the rhythm is irregularly irregular. That's the money phrase. The R to R intervals have absolutely no pattern to them.
Now for probably the most critical distinction you'll have to make. You see a wide, fast rhythm. Is it just an SVT with some bad wiring, or is it the life-threatening ventricular tachycardia? This is your checklist. These are the clues that scream VT. A really, really wide QRS, evidence of AV dissociation, just like we saw in complete heart block, and other weird things like fusion beats. These are all signs that the rhythm is starting in the ventricles. So, let's put it to the test. You've got this ECG in front of you, it's wide, it's fast, the QRS is 170 milliseconds, and you can see those little P waves just marching right through, completely ignoring the QRS complexes. So what's the call? Based on those criteria, with that extreme width and that slam dunk evidence of AV dissociation, this is ventricular tachycardia, no question.
And that really is the key. That's the whole point. Interpreting an ECG isn't some kind of magic trick. It's all about pattern recognition. If you are systematic, if you look at the waves, the intervals, the rhythm, and you apply those key criteria we just talked about, you can figure out even the most chaotic-looking ECG.
You know, the framework and all the criteria we've just covered are pulled from some really excellent work by Concialu, Makris, and Gao in their paper, Fundamentals of the Electrocardiogram and Common Cardiac Arrhythmias. It's a fantastic resource if you want to go even deeper.
Look, we've spent all this time talking about lines and squiggles on a piece of paper, but it's so important to remember what they actually represent. Every single one of these patterns tells a story, and the difference between a normal sinus rhythm and ventricular tachycardia isn't just a different pattern, it's the difference between a stable patient and a full-blown cardiac arrest. The real mastery is connecting what you see on the paper to the person right in front of you.